Ladies and gentlemen, thank you for those who returned. I think over the next 10 minutes people will come back in dribs and drabs. We're going to keep with aortic surgery. We're going to change now to the aortic arch and away from dissections. And we're looking at practical approaches such as minimizing brain injury, and we're also thinking in terms of the exam for people coming up to the exam who have to think through things like cerebral monitoring, etc. So we're taking this from different aspects for different audiences. We're going to start with Michael Sabetai, who spoke in the last session, who's my consultant colleague at St Thomas's, who's going to talk about cannulation and perfusion in aortic arch surgery. Michael.
Thanks very much, Chris. Indeed, this one's going to be a little bit more practical. It's just very difficult to navigate through the literature, mainly because it's so heterogeneous. You're very rarely going to find publications that are only aortic arch aneurysms or only aortic dissections. Usually there is an amalgamation of different cases. In any case, arterial cannulation in aortic arch surgery. A little bit of a different mode from the acute aortic dissection. Acute aortic dissection, just think of how you're going to bail out yourself from malperfusion. Aortic arch surgery and aneurysm surgery, just think of how you're going to bail out yourself from atheroembolic phenomena. The site of the arterial cannulation for aortic arch surgery is closely related to the type of aortic arch reconstruction you're going to do, and there's a lot of variety and a lot of things that you can do. And also on what sort of strategy are you planning to apply to protect the brain by means of antegrade cerebral perfusion, retrograde cerebral perfusion, or both. Aortas with aneurysms are usually more complex than dissections by meaning that atherosclerosis can give you a lot of debris. Again, the concept I think is very important for the antegrade arterial perfusion rather than central versus peripheral. The sites you can cannulate for ascending aorta and aortic arch surgery is the ascending aorta itself, axillary artery cannulation, innominate artery cannulation is also an option. And of course, femoral artery cannulation, which is being practiced by many, but it's retrograde arterial perfusion. Ascending aorta cannulation, the pros is that it's simple, it's accessible, it's in front of you. It allows time to do some proximal work should you elect to cross-clamp the aorta, and it's very easily combined with antegrade cerebral and retrograde cerebral perfusion. The cons is that sometimes you have a very grossly atherosclerotic aorta, so it's not an option. Very large aneurysms that they can occupy almost all the chest may preclude you from using the ascending aorta. Suspicion of an aortic leak, and also redo operations. And I'm just going to show you a case we did last week. It's dilated ascending aorta and an aortic arch. Just notes the distal calcification of the aorta. That will put me off of cannulating the femoral artery anyway. And we went for ascending aorta cannulation and replaced the whole arch with an Evita prosthesis. Axillary artery cannulation advantages, very easy for antegrade. It's an antegrade arterial perfusion. It's very easy to change from cardiopulmonary bypass to unilateral antegrade cerebral perfusion. And it allows for complex ascending aorta and aortic arch repairs. There is a trend towards better outcomes in terms of stroke and mortality. And it's also very useful in reduced situations. Disadvantages can be time-consuming to construct. You may not get adequate flows, so you may be unable to establish even full cardiopulmonary bypass. You may be not delivering antegrade cerebral perfusion, which is sufficient if it's very short. There is a chance of brachial plexus and subclavian vein injury. And also you may have upper limb ischemia, hence the 8mm Dacro graft end to side is much more popular nowadays. Disadvantage also is that this is a separate incision. Innominate artery cannulation advantages: there is no additional incision, it's easy to construct, it's easily accessible, you can control the bleeding, and there is a very easy delivery of antegrade cerebral perfusion. Disadvantages is that it can be short. You sometimes may have to manipulate head and neck vessels that are very atherosclerotic or indeed very narrow, and it may require complete occlusion of the artery in order to perform the anastomosis. You may not be able to use it in redo situations. Coming to the femoral artery, the advantage is that it's safe, it's accessible for emergency cannulation. You can even insert your guide wires and have it as a backup if a hasty access is anticipated, and it's very useful for redo operations. Disadvantages is the retrograde flow. Especially in atherosclerotic aortas, there is a potential of retrograde brain embolization, potential for retrograde dissection. Concomitant peripheral vascular disease makes it very challenging to impossible, and it can be very challenging in obese, maybe Texan patients. This situation, actually, it was a couple of months ago. This patient came and he had a very large ascending aortic aneurysm. I was getting ready for antegrade arterial cannulation in his aorta. As you may know, there is a pericardial effusion also there as well. And looking closer to it, and that was afterwards, unfortunately, you can see a little nipple there. And that explained the pericardial effusion because the aorta had ruptured, it had leaked, and it was only the superior vena cava which was acting as a plug. So there I am, median stenotomy, aiming for aortic arch cannulation, retracting the aorta a little bit on the right and pop. Fortunately, I managed to put my finger in. I had a very good assistant. We managed to go on fem bypass in less than 3 minutes and apply the cross clamp. Similar case 2 weeks later. A very big aneurysm again. You can see in the sagittal view that it occupies almost part of the chest. This time I was prepared to put the guide wires in femoral artery and femoral vein. Didn't need to, it was an uneventful entry, managed to cannulate up in the arch without any issues. And nowadays the whole thing has become very versatile. We have short grafts, long and curved grafts, 3 sidearms, 4 sidearms, frozen elephant trunks, and that really gives a lot of variability and flexibility. You can be really very creative. This is one of the configurations for aortic arch surgery, similar to a case we did with Chris. It was a redo and very complicated. We had every possible combination of cannulation and drainage. But what you can do is you can use a graft with a sidearm, do this one as an island, while we were on retrograde cerebral perfusion, then use the sidearm to switch to antegrade cerebral perfusion, and that gave us time to do 1-2 anastomosis, and then switch on to full cardiopulmonary bypass while we finished with this. So the possibilities are a lot. Just individualize and see what works best for you. I think that's this talk wouldn't have been complete without mentioning the landmark work of Kazui. I think he's the one who most likely popularized the sidearms, and you can see here the total arch replacement with sequential clamping and antegrade cerebral perfusion, which in his paper thinks that it was a major contributor to his improved morbidity and mortality. Some more evidence came about the axillary artery cannulation from Randall Grip's group. First publication for the routine use in 2004. They saw that axillary artery cannulation is versatile and safe. And furthermore, following up in 2008, but this time only for ascending aorta and atherosclerosis, saying that it improves stroke and mortality. And this one points to atherosclerotic debris, that they can increase the mortality in atherosclerotic aneurysms. The series from the Cleveland Clinic back in 2004, however, this paper involves dissections and aneurysms together. However, they did show a trend towards improved stroke rates and mortality. And more recently from Bologna, to say that femoral cannulation is equally good. And you can see in their conclusion that central and femoral cannulation are associated with similar risk of postoperative death. So the femoral artery is still there to be used. I think the most comprehensive and sensible review, which again confirms the better trends towards improved neurological outcome when the axillary artery is used. So in order to summarize, for cannulation strategies in aortic heart surgery, aim for antegrade arterial perfusion. Axillary and innominate artery cannulation can bail you out from atheroembolic stroke. The cannulation strategy is closely related to cerebral perfusion strategy, which can be antegrade, retrograde, or both. And femoral cannulation is safe. Thank you very much.
Thank you, Michael. Do you have any questions? Omar, you had a question relating to perfusion. Is that still relevant, or?
Actually, yes. Because I have different questions for Dr. Aortic, but great talk, Mike. If you have a patient that's in the dissection side, you've got a patient presenting with acute type A dissection. It's a type 1 going all the way down, and he's presenting with malperfusion of his legs. Mottled legs in acute ischemia. Is there an argument for going retrograde to try to establish flow there? Or would you still go aim for to get the true lumen? Because he's perfusing his true lumen, but in spite, he's still got acute ischemia.
It is possible, although I would stick with the main principles of repair of the type A dissection, which is identify the entry tear, and restore so that you can improve or increase the flow down the true lumen. And I think you doing that, A, most likely you save the patient, and B, you may buy yourself some time so you can deal with FEMPOP or any distal revascularization after you have repaired the proximal part.
Any questions? Michael, thank you very much.
Can I ask one question? In the kind of emergency, kind of quick cannulation, would you consider cannulating LV apex?
It is an option. It is an option, although if it works for you, you can try it. And I think it's most likely in desperate situations. If you anticipate, rupture or a significant leak, it may well try and put some cannula peripherally before you open and then cross-clamp the aorta as quickly as you can.
Yeah. Because it is fairly quick and fairly simple way of cannulating, because we've done it a few times in the kind of patient with the kind of crush on table. You just pass through the LV apex to the aortic valve. People say that you don't even need to go across the aortic valve. There's one group in Germany, they use a new cannula, pass it from superior pulmonary vein through the left atrium to the mitral valve, and tip sitting in the LV cavity, and then go on bypass with that.
This is the Kiel group, and there is the publication by Rahimi, but the reason I didn't mention that, although it's still an option, I think this is for really desperate situations. Other desperate situations that have been described is you can transect the aorta, you put the venous cannula in, you drain the patient, you transect the aorta, you stick the cannula in, you put a tape around it, and then you get on with it. But I think as a concept, we need to cover the first parts, and then this is also as a last resort. Again, antegrade arterial perfusion as a concept I think is very important. This is not to say that the femoral cannulation is not there to be used.
Because sometimes it will be useful if you have no time for femoral cannulation.
True, true.